Hi, I'm JC Chen. I'm currently a general surgery resident training at The Ohio State University, and I'll be discussing the impact of socioeconomic status, or SES, on weight loss outcomes following bariatric surgery. First off, I have nothing to disclose. We know that bariatric surgery is considered the most effective and sustainable method of weight loss. And research has shown that patients with lower SES tend to have higher BMIs and greater comorbidities, thereby making them more likely to be eligible for bariatric surgery. Our group has also previously shown that lower SES, particularly lower income, independently predicts poor short-term weight loss after bariatric surgery. This prompted us to dive further into the concept of SES, which is often said to be composed of three main components: income, education, and occupation. Education has historically been considered the most accurate proxy of SES when investigating impact on health outcomes. But there's been a paucity in research on the impact of income within the bariatric population. As such, we sought to examine the clinical differences in patients stratified by levels of income and education and evaluate the impact of these aspects of SES on weight loss outcomes up to 3 years after bariatric surgery. We did this through a retrospective chart review on patients who underwent bariatric surgery between 2014 and 2016. Using citydata.com, a public database recommended by data.gov, we estimated each patient's income based off their zip codes. Patients had self-reported their level of education, and we stratified our cohort into high or low income groups and patients with less than or equal to high school or greater than or equal to college education. Comparison of demographic information based off income showed that 17% of our patients were considered low income. There were significant differences in race, marital status, and education. Patients with lower income were predominantly Black, single, and had less than or equal to high school education. However, there were no differences in insurance type. When looking at medical history and post-operative outcomes, there were significant differences in baseline BMI, psychiatric diagnoses, and post-operative weight loss. Patients with lower income specifically had higher baseline BMIs and lower levels of anxiety. There were no differences in other obesity-related comorbidities, including type 2 diabetes, hypertension, hyperlipidemia, and sleep apnea. There was no difference in surgery type, yet there were significant differences in excess body weight loss up to 1 year. When stratifying by education, analysis of demographic information showed that 62% of our population had less than or equal to high school education. Patients with lower levels of education were noted to have lower income levels. However, similar to our analysis on income, there were no significant differences in insurance type. There were significant differences in baseline BMI, obesity-related comorbidities, psychiatric diagnoses, and surgery type. Specifically, patients with lower education had higher baseline BMIs, and in terms of medical comorbidities, patients with lower education had a higher prevalence of sleep apnea and bipolar disorder. Interestingly here, there was a difference in surgery type, in which patients with lower education were more likely to undergo Roux-en-Y gastric bypass. However, there was no difference in estimated and excess body weight loss at any time point examined. So in summary, we found that the majority of our population who underwent bariatric surgery had higher levels of income, and those with lower income were more likely to be Black, single, have less education, and have higher baseline BMIs. They were less likely to have anxiety, and there were no differences in insurance or surgery type, yet patients with lower income also had less excess body weight loss at all time points. The majority of our population also had less than or equal to high school education and were more likely to have less income, sleep apnea, bipolar disorder, and higher baseline BMIs. They were more likely to undergo Roux-en-Y gastric bypass. However, education made no difference in excess body weight loss at any time point. When we plotted these weight loss outcomes, there was a striking difference in the low income group, relative to any of the other groups. This effect was considered statistically significant in the low-income group out to 1 year postoperatively. Our study, of course, has its limitations. This was a retrospective review of patients at a single institution, which thereby decreases the ability to generalize our data to the entire bariatric population. Income was also estimated based off census data rather than self-report, which may have over or underestimated some of our patients' actual income levels. We did notice there was a significant drop in follow-up after 1 year post-op as well, which may have skewed our later outcomes. And because we focused on univariate analyses, the study did not account for any potential confounders such as race or the impact of food deserts. Nevertheless, our data suggests that income, not education, seems to decrease postoperative weight outcomes up to 1 year following bariatric surgery. There were no differences in insurance status or surgery type between income levels, but patients with lower education were more likely to undergo Roux-en-Y gastric bypass. Despite this, there was no difference in weight loss outcomes based on level of education. We plan to refine these results by examining the impact of race, income, and the intersectionality of both components. Similarly, with zip code data, an area of exploration would be to investigate the differences between rural and urban geographical types in relation to distance from the nearest accessible grocery store, and whether there are differences in outcomes based off the presence of food deserts. And with that, I'd like to say thank you for listening in.